Good afternoon and good evening, everyone. My name is Sarah DeFeo, and I'm the Director of Scientific Affairs here at the Ovarian Cancer Research Fund. And I want to thank you all for joining us today for what should be a very interesting presentation by Dr. Andrew Burchuk on early detection and screening of ovarian cancer. And I want to thank Genentech for their generous support of our webinar series this year. Ovarian Cancer Research Fund is the largest nonprofit organization in the United States dedicated exclusively to funding ovarian cancer research. And our mission is to fund scientific research that leads to more effective detection, treatment, and ultimately a cure for ovarian cancer. Since 1998, we've awarded nearly $45 million in research grants to investigators across the country. So just a few housekeeping notes here as we get started. All call participants will be in listen mode for the duration of the webinar. And after Dr. Burchuk gives his presentation, we will have some time for Q&A. Now, throughout the presentation, as you think of questions, you can submit them via that little Q&A chat box that appears on the right-hand side of your screen. Now, you won't see the questions that other people are submitting, and no one will be able to see your questions that you're asking, but I will be able to see them all. So out of the questions that are submitted, I'll select some to ask Dr. Burchuk. So without further ado, let's get started. Again, we're thrilled to have Dr. Burchuk with us today. He is the director of Duke University's Division of Gynecologic Oncology and holds the F. Baird Carter Distinguished Professorship there at Duke. He's a nationally recognized ovarian cancer researcher and a leader in his field who also maintains a very busy clinical practice. And Dr. Burchuk has many professional accomplishments. He was president of the Society of Gynecologic Oncologists from 2007 to 2008, and for many years was chair of OCRF's Scientific Advisory Committee, to name just two. And Dr. Burchuk has always been a wonderful supporter and champion of OCRF, and we're so pleased that he's agreed to spend some time with us today. So without further ado, we'll pass it over to him. Andy, you can get started.
Thank you, Sarah. Working with the Ovarian Cancer Research Fund has been certainly one of the most rewarding activities that I've been involved in my career in the field of ovarian cancer. And it's been really gratifying to see the growth in the amount of funding that OCRF has been able to provide to researchers over the past decade. I think it's grown from about $100,000 a year to over $5 million a year. So OCRF's really doing quite a bit to help us solve the ovarian cancer problem going forward. I think it's obvious to everybody, and many of OCRF's supporters are constantly reminding us what we need is a screening test for ovarian cancer so we can detect it early, like breast cancer or cervical cancer. And it's been much more difficult to develop a screening test for ovarian cancer, but obviously there's a great deal of work ongoing in this area, so I'd like to update you on what's happening and what the prospects are for seeing an early detection test. So the holy grail is to develop a test that will allow us to detect ovarian cancer while it's still confined to the ovary, where we can go in surgically and remove the mass in the ovary before cancer is spread. And in cases that are diagnosed at stage 1, the cure rate is about 85 or 90%. So really what we've focused on is the idea that if we could find a test or some way to detect these cancers earlier when they're stage 1, we could really have a huge impact on mortality from this disease. Unfortunately, in 2012, we're still diagnosing most patients with advanced stage disease where the cancer has spread out throughout the abdominal cavity. And this picture is taken through a laparoscope that's in the belly button and looking up to the right diaphragm, which separates the abdomen from the chest. And at the bottom, you can see the liver. And then on the top, there are all those little speckles, which are little implants of ovarian cancer. So unfortunately, it's fairly easy for ovarian cancer to spread in this way by just diffusing through the abdominal cavity. One idea that's gained some traction in the last few years is the idea that if women were made more aware of the symptoms of ovarian cancer, this might be one thing that would be helpful, because if women were diagnosed earlier, again, we might find more of them in stage 1. And many patients with ovarian cancer can reflect retrospectively about the symptoms that they had, and that if only they'd gone to see a doctor sooner, or if only a doctor had, considered ovarian cancer as a possible cause of those symptoms, that maybe they would have been diagnosed earlier. But actually, when this has been studied rigorously, it really hasn't appeared to indicate that earlier recognition of symptoms is likely to have a major impact on early diagnosis of ovarian cancer. So this just shows that the time from first symptoms to diagnosis of ovarian cancer is about the same whether you have an advanced stage cancer, stage 3-4, an early stage cancer 1-2, or borderline tumor. So it doesn't really look like advanced stage cancers are associated with a longer time interval of having had symptoms. So although I certainly agree with those who feel that symptoms such as abdominal bloating, pain, frequent urination, we need physicians to think more about ovarian cancer and consider ordering a CA-125 or ultrasound when someone has those symptoms, but I'm not that optimistic that a broader sort of utility of symptoms recognition exists. So another thing that we've started to learn over the past decade or so is that what we call ovarian cancer mostly isn't ovarian cancer. So the common type of ovarian cancer that's responsible for most mortality in this disease is called epithelial ovarian cancer, or carcinoma, and we now know that probably ovarian carcinoma doesn't even really originate from ovarian cells. Rather, the most common type, the serous type at the left, probably originates from cells in the fallopian tube. Some of these cancers may originate directly in the fallopian tube, and by the time they're diagnosed, they involve the ovary, and so we think they're ovarian cancer. Or in some cases, fallopian tube cells may slough off the tube and plant on the ovary, and so the cancer grows in the ovary, and we think it's ovarian cancer. But these serous ovarian cancers are probably mostly fallopian tube cancers. And then the endometrioid and clear cell types, which are the next most common to serous, probably arise from patches of endometriosis. Endometriosis is caused by menstruation out the end of the fallopian tubes, and endometrial tissue can plant on the ovary or the fallopian tubes or elsewhere around the pelvis, and probably most of these cancers that are endometrioid and clear cell arise from deposits of endometriosis on the ovary or throughout the pelvis. And so the very first slide I showed you with the big tumor in the ovary and detecting something as stage 1, if you think that these carcinomas of the ovary actually start from endometriosis and fallopian tube cells that have floated away, it's much more difficult to think about diagnosing them early in just the ovary. So there are a number of impediments to early detection of ovarian cancer. Some I've already alluded to, but the fact that the ovaries and fallopian tubes are relatively inaccessible, compared to, say, the breast or cervix, makes them harder to screen for cancer. The big success we've had with early detection in cervix cancer is because we can detect it in a precancerous phase when there's just dysplasia, and we can treat it before it ever progresses to cancer. We don't really have a well-identified pre-invasive lesion for ovarian cancer that we can easily treat and prevent cancer from developing. The other thing is that early detection is easier in general and more cost-effective in cancers that are common, and ovarian cancer is relatively uncommon. We discussed the issue of symptoms probably not being that helpful. Then there's also the issue for any type of cancer where you do screening, that detection of cancers with screening is going to tend to detect cancers that are less aggressive. More indolent cancers are going to tend to be detected with screening, and that really, to be worth the cost of screening, you must not only detect cancers but also prevent deaths. And I think if you've been looking at the New York Times and other media this week, you've seen the U.S. Preventive Task Force Service has just come out recommending against routine PSA screening for prostate cancer. And I think the main issue that they're focusing on there is just the fact that PSA may be able to prevent, or may be able to detect prostate cancers, but that it's preferentially detecting fairly indolent disease that wouldn't be causing deaths, and that ultimately PSA may not reduce the death rate from prostate cancer, and therefore it's not worth spending the money to do prostate screening, and not worth all the angst that a lot of men who have false positive tests go through with worry and other diagnostic procedures that are costly and painful. So just a slide here to address the issue of indolent versus virulent cancers. Here the red line is a point in time where you do an annual screen, say a CA-125 or an ultrasound, and at the bottom are slowly progressive cancers, which are going to be in an early stage for a longer period of time, and at the top are rapidly progressive cancers, which are going to be in an early stage for a shorter period of time. And you can see that an annual screen is more likely to detect slowly progressive cancers at an early stage just because they're in an early stage for a longer period of time. So it means that in your fishing net of screening for ovarian cancer, you're going to tend to preferentially detect cancers that are less likely to be lethal to begin with. Again, similar to the prostate analogy. And then lead time bias is another issue in screening. Here you can see at the top a bar that maps time from, say, a present clinical diagnosis without screening through diagnosis, treatment, and then eventually death from cancer. Well, you know, if screening simply moves back the time of diagnosis but doesn't change whether or not you die of the cancer, again, that's not worth the trouble and cost of doing screening. To actually have screening be worthwhile, you have to change the outcome, not just have a patient know that they have cancer for a longer period of their life but still die of the cancer anyway. So if you think about a cancer like ovarian cancer, which is relatively rare, this slide kind of takes you through some of the math of why it's problematic to screen for relatively rare cancer. So if you have 100,000 women, the math would tell you that about 40 of those should develop ovarian cancer in a year. It may sound like a very good screening test if it has 100% sensitivity and 99% specificity. What that means, 100% sensitivity says that if ovarian cancer is there, that the test will always pick it up 100% of the time. And specificity of 99% says that if a woman doesn't have ovarian cancer, 99% of the time it'll say she doesn't have ovarian cancer, but 1% of the time it will say that she does have cancer. If you take a screening test with that sort of sensitivity and specificity, which sounds great, 100% sensitivity, 99% specificity, unfortunately the positive predictive value of a positive screen is only 3.8%. So only 3.8% of the time will a positive test mean that there's ovarian cancer there. And you'll have to do 26 surgeries, assuming you operate on everybody with a positive test, per single case of ovarian cancer detected. And to detect all 40 of those ovarian cancers in 100,000 women, you'll have to do about 1,052 surgeries. So about 1% of the women would have to undergo surgery to detect those 40 cases. So one of the big questions with screening is what is an acceptable positive predictive value? And I think that in the meetings and discussions I've been involved in, people tend to focus on about a 10% positive predictive value. So they'll be okay with doing maybe 10 surgeries for every case of ovarian cancer predicted. So again, I've alluded to screening modalities, ultrasound and CA-125. This is an ultrasound picture where you can see there's not only a mass in the ovary, the big cyst is the black circle, but inside of that cyst or mass, there's on the left side a very irregular growth of tissue. In general, benign tumors don't have those kinds of irregular fleshy sorts of growths inside. So this is an ultrasound that not only shows an enlargement in the ovarian mass, but also something that's very suspicious and turned out to be an ovarian carcinoma. The other screening modality that's been talked about is the CA-125 blood test. It's elevated in most patients with advanced ovarian cancer and in some with early stage ovarian cancer. We order CA-125 all the time on patients with ovarian cancer because when the disease is growing, the level rises. When the disease is shrinking, the level falls. So it's a very good indicator of what's happening with ovarian cancer during treatment. It's problematic for screening because about 3% of women over age 50 who are in menopause have an elevated level. And that's because CA-125 can be elevated by things other than ovarian cancer, pregnancy, endometriosis, fibroids, liver, heart, or kidney failure, anything that irritates the peritoneal cavity, peritonitis. So CA-125 has been looked at, though, in the setting of potential use as a screening tool. And some of you have probably heard of the PLCO, the prostate, lung, colon, and ovarian screening trial that was started about 20 years ago by the National Cancer Institute. And for the ovarian part of the trial, about 78,000 women were randomized to screening or no screening. Those who were screened got an annual CA-125 for 6 years, a yearly ultrasound for 4 years. follow-up of abnormal test results were at the discretion of the patient's primary physician, but these patients were followed for a good 12 years to see what the outcome would be. And just looking at the initial screen in the first year of the study, 2% of the initially screened group of 28,000 wound up having surgery because of an elevated CA125 or abnormal ultrasound. The positive predictive value of an abnormal CA125 was about 3 to 4%. For an ultrasound, it was 1%. However, when both tests were positive, the predictive value was 23%, which starts to sound pretty good. It's over that 10% that we said we might find acceptable. This just shows the schema. Again, 78,000 subjects, about 39,000 with no screening, 39,000 with screening. Over the course of the study, 176 ovarian cancers were detected in the non-screen group, of which 77% were advanced stage. In the screen group, there were 212 ovarian cancers, 78% were advanced stage, so no difference in the stage distribution. And interestingly, there were 118 ovarian cancer deaths in the screened arm and only 100 ovarian cancer deaths in the non-screened arm. So actually, the ovarian cancer mortality was not reduced. It was not statistically significantly different, even though, if you look at this, there were more deaths in the screened arm than the non-screened arm. That was not statistically significant. But in the screened arm, if you look at the second bullet there, 3,200 women had surgeries from a false positive screen, and 5% of those, or 166 women, had at least one serious complication related to the surgery. So the conclusion from the PLCO ovarian cancer screening paper that was published in JAMA, the Journal of American Medical Association, in 2011, was that screening did not reduce mortality from ovarian cancer, but did cause harm. So ovarian cancer screening could not be recommended based on the PLCO study. Now, one of the weaknesses of the PLCO study is that it was based on an annual CA125. That was considered a positive screen, but we know that many of the falsely elevated CA125 levels, if you follow them over time, they tend to remain flat. So this graph here shows the serial CA125 levels from 6 patients, and the ones with the red circles are patients whose CA125 rose, and they were found to have ovarian cancer, whereas the 3 other straight line curves with the green circles are from women who didn't turn out to have ovarian cancer, and their CA125 levels were stable over time. So you can use CA125 trend over time as a screening test as opposed to just an annual CA125. So the UKCTOCS trial is a population-based trial that's being done in the United Kingdom that is quite far along. It's maybe the largest clinical trial ever done in the world of any disease. It's got over 200,000 women, and they were divided into 3 arms: a control group with no screening, 100,000 women, 50,000 women with an annual ultrasound screen, and then 50,000 women being screened using the CA125 test, but not just as an annual value, but as I described in the previous slide, where if it's elevated, then you follow it up and serially see if it's rising before you consider it a positive test, and then also then move on to ultrasound or surgery. And so the initial screen from the UKCTOCS trial of using the multimodal screening arm with CA125 followed by ultrasound and surgery, sensitivity was about 90%, specificity 99.8%, positive predictive value 35%, so only about 3 operations for every ovarian cancer case detected. And most interestingly, 50% of the ovarian cancer detected in this UKCTOCS trial were in an early stage. So again, the goal of screening is to detect ovarian cancer in an early stage because those are the cases that primarily can be cured. So the 50% early stage cases in the UKCTOCS trial is better. It's about twice as good as what was seen in the screening and control arms of the PLCO study. And so the big question that's out there, and hopefully will be answered by 2014 or 2015, is whether the multimodal screening arm of the UKCTOCS trial will be shown to reduce ovarian cancer mortality. So again, 50% detection in an early stage is encouraging, but early stage is stage 1 and stage 2 in this trial, so it's not entirely clear, even though they detected a higher fraction in early stage, whether this will translate into a benefit in terms of survival. So another thing I wanted to mention in the realm of early detection is that screening refers to like an annual test that's done on a population of women that's completely asymptomatic. So, you don't have a mammogram or a pap smear because you've got symptoms of those diseases, cervical cancer or breast cancer. Mammogram and pap smear are done in a totally asymptomatic woman annually with the idea of finding something. And that's what we were talking about with the PLCO and UKCTOCS trials. But another sort of slant on early detection is that most women with ovarian cancer present with a pelvic mass. And so as a medical profession and as a patient, you'd like to know whether that mass is an ovarian cancer that needs to come out immediately and ideally have surgery with a subspecialist like a gynecologic oncologist, or whether it's a mass that's maybe not worrisome and could be followed, or if it's benign, could potentially have surgery with a general OBGYN. And in fact, most ovarian masses are benign. It's only the minority that are cancer. So CA-125 has certainly been used for a long time to discriminate benign from malignant pelvic masses. In the past 2 years, 2 other tests have been approved for trying to distinguish benign from malignant pelvic masses. The OVA1 test has been FDA approved, and it uses CA-125 and then 4 other markers that were discovered using serum proteomic research techniques. And basically, with a sample of blood, they measure all these markers and come up with a single numeric result based on a formula. And then there's a cutoff for premenopausal and a cutoff for postmenopausal, where if it's over a certain level, they say that it's a positive result. One of the downsides of the OVA1 test is that it costs $650 compared to $30 for a CA-125. So it's more than 20 times as expensive. And as I'll show you a little further on in this presentation, I'm not sure you can make a strong argument that it's actually better or appreciably better. So another test that's been developed in the last 2 years is the HE4 ROMA test that's also used for potentially distinguishing benign from malignant pelvic masses. One of the problems with CA-125 as an individual marker is that, again, it's often elevated with other conditions beyond ovarian cancer, particularly something like endometriosis, which is very common. HE4, fortunately, is not as likely to be elevated in benign conditions, particularly endometriosis. So HE4 has been approved by the FDA, like CA-125, for monitoring ovarian cancer over time in the United States, but in Europe, the combination of HE4 and CA-125, again, measuring those 2 markers and combining them in a formula which they call ROMA, risk of ovarian cancer malignant algorithm, is also used for distinguishing benign from malignant pelvic masses. And if you actually kind of compare apples to apples between ROMA, CA-125, and OVA1, they're fairly similar. You can adjust the sensitivity and specificity of any of these tests based on where you use the cutoff markers or the cutoffs for the various markers. But if you look at OVA1, ROMA, and CA-125 and adjust them to the sensitivity of OVA1, 93%, at a 93% sensitivity, the specificity of OVA1 is 43%, ROMA is 60%, and CA-125, 55%. So, my take on these tests which are used for distinguishing a benign from malignant pelvic mass is that they're all fairly similar, and that HE4 ROMA and OVA1 are not really a major improvement over CA-125. But fortunately, we do have several good marker tests that can help a woman with a pelvic mass decide whether she needs surgery or whether that surgery should be done with a general OBGYN or a gynecologic oncologist. Again, ideally, if a woman has ovarian cancer, you'd like a gynecologic oncologist doing the surgery. If it appears to be early stage, a gynecologic oncologist can perform a more extensive surgery with staging to make sure it really is early stage. And if there is advanced stage disease found, then a gynecologic oncologist is in the best position to optimally resect the cancer before the patient moves on to chemotherapy. So right now, we don't have a good screening test for ovarian cancer that can be used in the general population, but we do know quite a bit about risk factors for ovarian cancer that can be used to help guide patients towards strategies for reducing the risk of getting ovarian cancer. So factors that increase risk of ovarian cancer include aging. The older you are, the higher your risk of ovarian cancer, because the average age is in the 60s and continues to be a high incidence disease in the 70s, but rare in younger women. Family history of breast and ovarian cancer increases risk because of BRCA1 and 2, which we'll talk about a little bit. Women who've not had children or have had infertility or endometriosis have increased risk. Oral contraceptive pills, pregnancy, breastfeeding, and tubal ligation dramatically reduce risk. So women who've used the pill for 5 years or had 3 children reduce their risk of ovarian cancer by about 50%. Tubal ligation reduces risk by about 30%. So this is just a meta-analysis that was done of a number of epidemiological studies showing that the longer a woman is on oral contraceptives, the more she reduces her risk of ovarian cancer. And so I think that women who are at increased risk for ovarian cancer based on, say, having a lot of children, or rather not having children, having a lot of children reduces your risk, not having children increases your risk, or endometriosis, which increases your risk, or perhaps genetic risk factors like BRCA1 or 2 or others that we'll talk about. I think the data on oral contraceptives and prevention of ovarian cancer is compelling. And then, again, genetic risk of ovarian cancer has been sort of the new kid on the block in the last 15 years. BRCA1 and 2 were discovered in the mid-1990s, and testing for mutations in these genes can be performed through Myriad Genetic Laboratories in Salt Lake City. And only about 0.5% of the U.S. population carries mutations in BRCA1 or 2, but out of that 0.5% of women come about 10% of all the epithelial ovarian cancer. So based on recognition of women who carry BRCA1 and 2 mutations, we could theoretically prevent about 10% of ovarian cancers right off the bat. Unfortunately, more than 15 years after the discovery of these genes, I'm still seeing women in my practice who come with advanced stage ovarian cancer, and they have BRCA1 and 2 mutations. And so, in theory, they could have had prophylactic surgery for removal of their tubes and ovaries, in their late 30s or early 40s when they finish their family, and we could have prevented ovarian cancer. So at this point, there's a well-accepted paradigm of testing for BRCA1 and 2 mutations in high-risk families and performing prophylactic surgery. One of the impediments there has been the high cost of the Myriad Genetics BRCA1 and 2 test, which is about $3,000. But Myriad's patents are being challenged, and in any event will probably expire within 5 years. The cost of DNA sequencing is declining so rapidly that by that time, it's probably going to be less expensive to sequence the entire human genome than to do the Myriad tests. So I anticipate in the near future that probably BRCA1 and 2 testing will become much more widely available, and hopefully we'll be able to maximize the potential to prevent ovarian cancer by recognizing all those women who carry mutations in these genes. In addition, there may be other genetic risk factors, so-called SNPs, or single nucleotide polymorphisms. There's this common disease, common variant hypothesis where, unlike BRCA1 and 2 mutations, which dramatically increase your risk of ovarian cancer, it's possible that there may be other genetic variants that in this example would be carried by, say, 5% of the population that would increase one's risk of ovarian cancer less dramatically, but increase it nonetheless. And so you wouldn't see with these SNPs clustering of cancer in families dramatically like you see with BRCA1 and 2, but these genetic variants could be responsible for up to 20% of ovarian cancer cases. And so I think that it's important for women to understand what their risk of ovarian cancer might be. Project HOPE, which was done by Al Goldstein in collaboration with the Women's Cancer Foundation, they prepared this brochure, which is available online. informing women about what their risk factors are for ovarian cancer and how to reduce their risk of ovarian cancer through potentially a use of oral contraceptives and prophylactic surgery. I think this was a very noble and useful effort, and would encourage you to perhaps take a look at this brochure, which can be downloaded as a PDF. But I hope that we're headed for a future where we can do a personalized approach to risk reduction and reducing mortality from ovarian cancer. So it may be for relatively rare cancers like ovarian cancer that we can't really take a population screening approach the way we do for breast cancer with mammography or colon cancer with colonoscopy. You know, and you don't think of cervical cancer as a common cancer because screening's been so successful, but in the absence of screening, cervical cancer is a very common cancer. So cervix cancer, breast cancer, and colon cancer are kind of the poster children for screening everyone. But it may be that for diseases like ovarian cancer or pancreatic, those kind of next level of disease incidence cancers, that we may need to have different screening strategies or prevention strategies based on assessment of each individual woman's risk. So I think for the highest risk group, those are going to be women who carry BRCA1 and 2 mutations. You know, the average woman's risk of ovarian cancer in the population is about 1%. A BRCA1 carrier may have a lifetime risk as high as 60%. So that's a 60-fold increased risk of ovarian cancer. I think at this point, most of us feel that the best option for those women is going to be to have prophylactic surgery in their late 30s or around age 40 when they complete their family. It may be, I think, the next step we're working towards is identifying a moderate risk group based on these other genetic variants I've talked about, or other epidemiological risk factors like how many children you've had, whether or not you've breastfed, whether or not you've used the pill, whether or not you've had endometriosis. And ideally, we would be able to identify a moderate risk population that has maybe a 3 to 6% lifetime risk of ovarian cancer, but some of those women might want to have prophylactic surgery. Others might want to do screening. You know, again, one of the difficulties of screening that make it difficult to have it be cost effective is just the low incidence of disease in the population. But all of a sudden, if you start to focus CA125 and ultrasound screening on a moderate risk population that's going to have a higher incidence of the disease, then you know, screening might all of a sudden become more cost effective and worthwhile in this fraction of the population. And then finally, whether or not the oral contraceptive pill will ever become more widely appreciated as a chemopreventive, I don't know. Obviously, the main intent of oral contraceptives is to prevent pregnancy, and they're the safest and most effective means of contraception for women during the reproductive years. But certainly the indications for oral contraceptives have, you know, gone beyond just contraception. They're effective treatment of endometriosis, pelvic pain, and do also have the benefit of reducing a woman's risk of ovarian cancer. So you can see there, from low risk to moderate risk to high risk, hopefully we're moving in a direction of personalized strategies for prevention and early detection of ovarian cancer. So with that, I think I will end my comments, and I hope that you found them useful and informative, and I'm happy to answer any questions at this point.
Great. Dr. Burchuk, thank you very much. We do have a few questions, and I just want to remind everybody to if you have questions, you can submit them via the Q&A box that is on your screen. A first question for you is, you mentioned at the start of your presentation about ovarian cancer, how it might be starting, or there's theories about it starting in the fallopian tube. And I'm wondering if you can comment on how a better understanding of the origins of ovarian cancer might be helpful with early detection.
Well, you know, for one thing, we've been looking in the wrong place. We've spent many years studying ovaries from high-risk women and looking for early precancerous changes, and there was a lot of controversy about whether we were seeing them or not seeing them. But just in the last few years, I think there's been a fairly quick and broad consensus that we're seeing precancerous lesions in the ends of the fallopian tubes that are near the ovaries. And so, one of the impediments to screening and early detection I mentioned was just that we don't know what the pre-invasive lesion is or where to look for it or how to detect it well. If we now know where it is and what it is, I still don't see an easy way to detect it, but maybe someone will develop a tiny scope that can go up through the uterus and into the fallopian tube and look, or perform a sampling of cells like a pap smear from the fallopian tube. I don't know. This is all kind of like Star Wars sort of stuff, but I think at least if we start to have a better understanding of the pre-invasive lesion and where it is, then we can begin to approach technologies for trying to look for early changes that we could detect. Or, again, one of the sort of impediments to doing prophylactic removal of the tubes and ovaries more widely has been that it's going to put you in premature menopause, which isn't good for a woman's health. But if we really think that these precancers are developing in the fallopian tube, we might be able to just start removing the fallopian tubes and not removing the ovaries. So a woman could have prophylactic surgery, and retain her ovaries. We're not advocating that yet as safe or proven. I think we're pretty much still removing the tubes and ovaries prophylactically. But if we can really prove and get a more solid footing that we think the disease is starting in the fallopian tube, then maybe we can do these just removal of the fallopian tube in the high-risk women. Or, a lot of women have tubal ligation for contraception, and typically we remove just a small segment of the fallopian tube. We don't remove the end of it or the whole thing. But if we really believe these cancers starting in the fallopian tube, maybe women who have a tubal ligation for contraception should have the whole tube removed. So just kind of looking towards the future with some speculative comments there. Sarah? Hello?
Okay, can you guys hear me?
Yeah, I can.
Okay, sorry about that, everybody. We had some technical problems here on our end. Our phone got cut off. So thank you very much. We'll continue with the Q&A. While you were talking, Dr. Burchuk, someone threw out the question, if a woman has had her tubes tied, can that increase or decrease the risk of having ovarian cancer?
Well, most studies would say that having your tubes tied would reduce your risk by about 30%.
Okay.
Again, we're not sure entirely why. I don't know how much you heard or others heard of my comments before, but now that we think a lot of these cancers start in the fallopian tube, it may be that removing part of the fallopian tube reduces risk, and maybe we should be removing the whole fallopian tube, although we don't know that for sure yet. But there's also the theory that some ovarian cancers may be caused by carcinogens that migrate from outside the body through the vagina and cervix and uterus and up the fallopian tube. And so it may be that by tying off the fallopian tubes, it blocks off a path. Some people have postulated that talc and talcum powder can get up through the genital tract to the tubes and ovaries. And so, maybe it's not so much removing part of the tube that protects with tubal ligation, but that it blocks a pathway for carcinogen, like possibly talc or something else.
Okay, and can you comment about the use of hormone replacement therapy in postmenopausal women and potential risk of ovarian cancer? Do you have any information about that? Has any research been done on that?
There has been research done, and it hasn't been entirely consistent, but I think there's a growing sense from the various studies that have been done that hormone replacement therapy does slightly increase your risk of ovarian cancer, but not to the extent that it increases breast cancer risk. And again, a lot of these studies are too small to really study well. Does it increase your risk if you're on estrogen alone versus estrogen plus progestin? There's some sense in some studies that if you're on the estrogen and progestin together, it might be not increasing your risk, but just estrogen alone might be. But again, that's not entirely clear or consistent between studies. But I do think that there is a sense that there's a slightly increased risk with estrogen replacement therapy, but not nearly to the extent that it increases risk of thromboembolic disease or breast cancer. So it's a minor consideration relative to breast cancer and blood clot risk.
Okay. Here's another question. Is there a relationship between the detection of benign ovarian cysts and ovarian cancer in the future?
You know, it really does not seem that there is. Again, I think increasingly our feeling is that ovarian cancers arise from the fallopian tube epithelium or from endometriosis that's implanted on the ovaries or in the pelvis. So, you know, the ovary is basically a cyst-making machine, and benign cysts and even benign tumors that develop in the ovary in general don't seem to be the precursors of ovarian cancer that's a highly lethal disease.
I'm wondering if you can talk a little bit more about why false positives are such a problem. Understandably, it's easy for people to say, you know, so what if they're false positives? If it catches a cancer, is it worth it? Can you talk a little bit more about that issue?
Sure. I think, again, it gets back to that slide where I said a 99% specificity means that 99% of the time when a woman doesn't have cancer, the test will say you don't have cancer, but 1% of the time it says that you will. And so the problem is that, like, out of that 100,000 women, you know, there were going to be 40 with ovarian cancer. There are going to be 99,960 that don't have ovarian cancer. So when you talk about 1% of those women who aren't going to have ovarian cancer having a positive test, you know, the number of false positive tests just absolutely swamps the number of true positive tests. And so when you have a false positive CA-125, you know, you're going to be alarming a woman, you're going to be doing more CA-125s, you're going to be doing ultrasounds, you're going to be doing CAT scans, you're going to be doing surgeries. So like you could see what happened in the PLCO study, you know, there were a few thousand surgeries, and when you do that many surgeries, there were 5% of those women who had significant complications from the surgery, you know, not to mention the cost of all these additional tests and surgeries and worries. And at the end of the day, if you don't prove that all that reduced the death rate from ovarian cancer, then it's just really not worth it.
Okay, thanks. There's often so much focus on detecting early symptoms, which seems to put at least some of the onus on the individual. A couple of years ago, there was a fairly well-publicized symptom study, which was reported in the New York Times by Dr. Barbara Goff out in Washington. How does this fit in with your experience? Do you know about anything about
Yes, I'm certainly aware of Dr. Goff's research, and I think she's been a leader in this area of research of trying to investigate the relationship between symptoms and stage and presentation of ovarian cancer. Barbara's also a friend. Again, I admire her. But I think that at this point in time, there's really no evidence that a greater attention to symptoms is going to lead to earlier enough diagnosis to cure more women with ovarian cancer because they're presenting at an earlier stage. So, you know, Barbara is continuing to do this research and to get down to a finer granularity to see, you know, if there is some potential utility of combining symptom recognition with a screening test like CA-125 or ultrasound. But you know, in the meantime, as I said, I think that it bothers me that physicians, particularly general medical doctors, family practitioners, when women have abdominal symptoms and the sort of symptoms that you associate with ovarian cancer, they don't think about ovarian cancer. They think about cholecystitis or irritable bowel or urinary tract infection. You know, I think when women do have these symptoms, that it's medically appropriate to perform a CA-125 and an ultrasound because ovarian cancer should be in that differential diagnosis. So although we're not ready, we don't have the evidence to say that symptoms should be, you know, something that should be more widely recognized because it's going to lead to earlier detection that's going to reduce mortality. I think it's just good medicine when you have these sort of symptoms to include ovarian cancer in the differential and for a physician to order those tests and to consider the possibility that it might be ovarian cancer.
So I think we will wrap up here. And again, I want to thank you, Dr. Burchuk, for a really great presentation on a topic that I know is of interest to so many people. And I want to thank everybody who called in tonight. And shortly after this call, this webinar will be archived on the OCRF website, along with presentation that we had a couple weeks ago. So you can always get more information about ovarian cancer research and our upcoming presentations on the OCRF website, which is www.ocrf.org. And thank you all again, and have a great evening.
Thank you, Sarah. It's been a pleasure to participate.